Everyone, welcome back to Nurse Spicy Nursing. Today we're going to be doing a little bit of a cardiovascular lecture. This one's not going to be as in depth as the one that I did a few months ago. The purpose of this one is going to be more so hopefully helping you guys kind of remember very fine details about the cardiovascular system using like mnemonics and stuff like that. Um, just so that it sticks better and you guys can go to your test and feel a lot more confident about the material and be able to actually remember it rather than just study for your test, take your test, and then forget all of it. This is more of something that can hopefully stay with you long term. Now, there are going to be two different PowerPoints that are associated with this lecture. However, those of you who know me know that my voice is very prone to going out. So I'm going to do this first one and then I'm going to upload that second PowerPoint just so that you guys can also go and get like the most out of this, right? Because when my voice starts to go, I know it can be very hard to understand what I'm saying. So I want you guys to be able to obtain all of the information that you need for your testing purposes and eventually for your NCLEX from this lecture rather than you listening to someone who can barely talk drone on. So let's get right into it. Things I want you guys to remember and things that are going to be very, very important when we're talking about the heart is the difference between diastole and systole. So if you can remember, systole is squeezing. It is your heart actually squeezing and ejecting the blood from one place to another. Diastole is your heart decompressing or your heart relaxing. So at this point, your heart should be able to relax and fill up with blood to prepare for that next pump, either the ventricles or the atria. It doesn't matter which is which, but that's how blood flow is working, right? So it goes from one place to another. Systole is always going to be that lub sound. So when we talk about how our normal heart rate is and we think of the lub dub, systole is S1 and diastole is S2. Now, going through the electrical pathway, I like to remember the electrical pathway as this SA node is you waking up first thing in the morning. You know, you're a little bit tired. You can get to 60, but eventually you'll wake up and get to, the the height of energy for the day. This is you first waking up in the morning. Your AV node is you going through your clinical shift. By the end of it, you're gonna be a little bit tired, right? And then your bundle of his and your Purjunky fibers is you just got home. All you want to do is take a shower and go straight to bed. So this is the least amount of energy or beats per minute that your heart can pump out is in your Purjunky fibers. If this pacemaker fails, if your SA node fails, your AV node kicks in, and if your AV node kicks in, your Purjunky fibers kick in. No one wants to do a 12-hour or 8-hour clinical shift on 20 to 40 beats per minute, right? We want to start on this SA node. We want to start with 60 to 100 beats per minute. We need more energy to get through that shift. Our energy is going to decrease during that shift, but we need a lot of energy to at least get there and get us moving. Some people remember the way of like the flow of the electrical conduction being send a big bounding pulse. So SA node, AV node, bundle of his bundle branches, and then Purjunky fibers. And then I need you guys to remember this also. A problem with how our heart is pumping can affect the electrical conduction of the heart, but also the electrical conduction of the heart will also affect the pumping. So these are a symbiotic relationship. They both need to be functioning properly to have a healthy and functioning heart. Okay, moving into a little bit more of the assessment portion of this. I want you guys to remember when we're thinking of your guys' patient stories, why they're coming in, a little bit of their health history. Don't forget that your health history is extremely important. So you're going to ask them about the onset of their chest pain, what provoked it. So if we're talking about someone who has unstable angina, right, or stable angina, were they exercising or were they at rest? If they were having an MI, let's say it just snowed outside. It's very, very common for people to have MIs when they're shoveling snow. So were they just shoveling snow? That's things that we have to ask them. What's the quality of their pain? Does it radiate anywhere? Quality means like kind of like what does it feel like almost? Is it stabbing? Is it shooting? That sort of thing. Radiation, does it radiate anywhere? For women, a heart attack can radiate up to our jaw or to that left shoulder. Some people even get epigastric pain. The severity. So this is your, on a scale of like 1 to 10, how bad is your pain? And then timing. When did it goes kind of with onset, like when did it start slash how long has it been going on? And is it something that's more acute or have you been consistently having chest pain for a very long time? Other things that you need to make sure that you keep in mind that are going to be extremely, extremely important. Their lifestyle. Do they smoke? Do they exercise? How many alcoholic beverages do they drink? Their family history. Remember, if they have a family history of CAD, hypertension, any cardiovascular things that increases their risk for other cardiac that increases that patient's risk for cardiovascular issues. And then cultural considerations. So if someone is of a specific religious background, giving them an a heart valve that comes from a pig may not be super duper great. It can be against their religion, and we don't want to do that. The other thing too, some cultures have foods that in Western medicine, they're unhealthy, they're just bad. We are not supposed to pass judgment on what someone may eat, okay? Because food is very cultural. That's not saying that we should be doing. Or let's say they have to get up and if they're of Islamic faith, they may have to get up and do their daily prayers. If they just had a heart cath and they went through their femoral artery and they need to sit still for 6 hours, they may not be able to practice that where they get up, sit on their mat and pray. So we have to make sure that we're also accommodating those sort of things because they have to keep their legs straight. How do we get them to be able to feel like they're still in line with their culture while also maintaining the safety of their patient is going to be very important. Okay. Now all of this and this next portion are all going to be before you actually kind of touch your patient. We want to get their health history and then actually like make sure that we're looking at them. And by looking at them, we can see, do they have any jugular vein distension? So they'll have like their veins in their neck will be kind of bulging outwards. It can make their neck look a little bit more triangular is kind of a bad word, but it can be a little bit triangular, or it could just be bulging in one portion of that artery or vein. this is what JVD means. It just means that there's a little bit of central venous pressure. A lot of times you're going to see it in fluid overload. JVD, ascites, and edema all point to someone who's having right-sided heart failure symptoms. Um, that doesn't necessarily mean that they have right-sided heart failure, but it could be right-sided heart failure symptoms, again, or just regular fluid overload. You don't need to have heart failure to have fluid overload. And then when you're looking at their chest, so this is not when we're talking about the PMI, this is not when you're actually listening. You want to be able to see if you can look at them and visibly see the pumping of their heart outside, like on the outside. So occasionally you'll be able to see a little bit of, you know, like seeing a little bit of it is normal. Seeing a little bit of the pulsation from the PMI is normal. However, if it's like pretty intense, because you have to remember like your rib cage is there too, and even though it's in the intercostal space, seeing a lot of it is going to be very abnormal. And when we see a lot of it, it's going to suggest something called hypertrophy. Hypertrophy means it's just the enlargement of that muscle. A lot of times, hypertrophy is going to be enlargement of the left side of the heart. Okay, so now we're getting into kind of the hands-on assessment. I want you guys to remember the mnemonic. 3 is 3. 2 is true. And 1 is wondering where it is. And 0 is oh no. So 3 is 3. 2 is true. 1 is wondering where it is. And 0 is oh no. So 3 is 3 sounds a little bit silly, right? But if you can remember, 3 is 3. 3 is greater than 2. So if 2 is true, we know that 3 is going to be too much. That may be easier for you. A pulse grading scale can also go up to 4, but remember a lot of times when we see 4, it can mean that like I don't want to say like their heart's about to explode, but a lot of times when you see a +4, their heart is really, really pumping and it's about to fail. So a bounding pulse a lot of times can mean that they just have it could mean that they have too much fluid on them. Sometimes a diminished pulse can be from edema and fluid overload as well. But there are other things that we have to make sure that we keep into account with that, right? So the temperature of their skin, does it feel cool? Is it clammy, that sort of thing? Or the color, do they have cyanosis? Like if this pedal pulse down here, if it was actually blue, like how this dot is, you're worried about poor circulation, right? Especially if you can't feel a pulse. These are going to be very important for your patients who, like, if they just had an MI and they're coming back from a cath lab after getting a PCI, we have to make sure that that pulse distally to where, so if they had, like, let's say they went in through their femoral artery, which is one of the most common places, femoral radial. If they went in through their femoral artery, you're going to be checking the pulses all below it. Most commonly, we check posterior tibial and pedal pulses. Sometimes we check popliteal if we have to, but these are going to be the most common because they're most distal. If you don't feel a pulse in any of those areas and they have cool skin, you're worried that something happened with that, like in cath lab, like there could be a bleed somewhere. So we just need to keep that in mind. That's why we really check. It's like a good reason why we check. Also checking their cap refill and if they have edema, because remember, edema can cause a diminished pulse, or an absent pulse. But if they do have an absent pulse, but let's say their skin is still warm, there's no signs of cyanosis, or anything like that, you are going to use a Doppler to make sure that you actually find that pulse. Now, if you can't find one on Doppler, that's a bad sign. Okay. So we talked about that lub dub sound already. Don't forget that your lub sound is the mitral and tricuspid valves that are closing. So if you're thinking of these 4 and 5, kind of like this, I don't know how I did that. That's wrong. This image here, don't look at that. Those are not the correct land. Sorry, guys. Those are not the correct landmarks. But the mitral and tricuspid valve. So mitral is going to be, that's actually like pretty close to where it is. It's normally at like the point of maximum impulse is really where you're going to be able to hear the mitral valve very, very well. And the tricuspid is just like a little bit over to the right and then shift up just a tad, and that's where you can hear that one. Erb's point's going to be the part where you can hear both of these sounds really well. And aortic is going to be, so pulmonic is going to be on, listening to the patient. This is pulmonic and this is aortic in this intercostal, second intercostal space, kind of next to the sternum. If that makes sense. And that's where you're going to be able to hear S2. Okay, so our extra beats. Now, there are going to be times when an S3 sound is normal. Athletes, young children, and pregnant women can have an S3 sound. It does not mean that they have heart failure. S3 is going to happen right after S2. So it's like a lub dub dub. Lub dub dub. Some people use the Kentucky. I like using lub dub dub just because it's easier for me. And it's kind of like, I don't want to say like sounds like a murmur because it doesn't. But it's kind of a swishing sound. So it could be like a lub dub swish. And it's just like extra fluid that's going through. And as for, some people can say a stiff wall because a lot of times it happens because of stiffness. If they have left ventricular hypertrophy, see aortic stenosis. Any type of stenosis can really cause an S4. Aortic is kind of the most common. Or if they have ischemia. So ischemia, don't forget, ischemia means like narrowing of a vasculature to reduce blood flow. Infarction, like in an MI, is also the narrowing of a artery to reduce blood flow, but with infarction, it causes cellular death. So that's the biggest difference between ischemia and infarction, is that infarction has the presence of cellular death. And this one happens before S1. So it's kind of like a, I say like a lub lub dub, if that helps you. But it's immediately right before S1. So this is just a little thing to help you guys remember. If you lay your patient on their left side, you lay your patient on the left side, it's a lot easier for you to hear an S3 and an S4 rather than if they're just sitting up. And then if you use your bell, so not the large portion of the stethoscope, the little portion, it's a lot easier to hear them too because they're a little bit lower sounding. Okay, so clicks, rubs, and snaps. So clicks are very high pitched. Like this is if someone is having an issue with their mitral valve and it's heard in early diastole. So if we go back up, early diastole is right after S2. Okay, so this is like an S3 type sound. Snaps are high pitched as well. Oh, sorry, it's early systole. My fault. Early systole is when clicks are heard. So that's kind of like in between S1 and S2. Because early diastole is here and then late diastole is in front of S1. So right before S2 is where you're going to hear the clicks. Right before S2, early systole. All right, snaps. These are heard in early diastole. So this is your S3 sound. This is for like mitral stenosis. And then rubs. I kid you not, if you're hearing a rub, like a pericardial friction rub, it sounds like if you know someone with the driest hands ever, and like let's say they're calloused and they rub their hands together, that's kind of what a friction rub sounds like. And then if a patient holds their breath in case of pericardial friction rub, it's going to be a lot easier for you to be able to hear if it's an actual pericardial friction rub or if it's a pleural friction rub. Because remember, you can get rubs in your lungs as well. So if we have them hold their breath, we can actually distinguish whether it's a rub from them breathing or if it's their heart. Okay, so the sound of turbulence. Script is a really great way for you guys to kind of remember how to keep organized the different types of turbulent blood flows. So site, where is it loudest? Like if it's mitral, it's going to be best heard kind of down here by PMI, right? Character, is it harsh or blowing? It's like a swoosh sound, or is it like a aggressive kind of thump? Does it radiate anywhere? Can you feel it up in if it's like aortic stenosis? Can you hear it up in the carotids? Intensity. Intensity is kind of like how loud it actually is. The pitch is whether it's a high or low pitch, and if it happens systolically or diastolically. This is really a great way, and that's how I can remember. That's how I normally remember like the mitral regurgitation and all of that. So if we're doing mitral regurgitation, it would be heard systolically. It's a blowing sound, and it can radiate to your axilla, which is like your armpit area. And your intensity is based on your patient, right? Because not every single patient has like a 1 grade. And then like the higher it goes, the more intense it is. Okay, heart failure. So if you guys can remember, left side is your lungs. So L and L, left and lungs. And right-sided is rest of the body, R and R, right and rest. Then you guys should be all good with the left-sided versus right-sided heart failure. Also keep in mind there's something called orthopnea, which means that if you are laying flat, you can't breathe. Make sure you guys remember what that means. And then ascites. So ascites is fluid buildup in your abdomen, and it's because of your hepatic portal vein. So if you guys can remember that ascites comes from the hepatic portal vein, you're going to be golden on kind of how ascites works. All of these are also called third spacing, which just means that fluid is in areas where it's not supposed to be. And hepatomegaly as well can be caused by this hepatic portal vein issue. Your hepatic portal vein is something that delivers, it doesn't have very highly oxygenated blood because it's a vein, but it's got a lot of nutrients in it, so it's very important for our liver. Okay, MI. So I just mentioned a little bit ago that an MI is like the difference here in an infarction versus ischemia is a lack of blood flow to an area. Infarction is also lack of blood flow, but they have tissue cell death. So there's a STEMI versus an NSTEMI. A STEMI is going to be a ST elevated myocardial infarction. So when we're looking at their EKG, that ST segment is pretty highly elevated. An NSTEMI is a non-ST elevated myocardial infarction. So they will have a depression in their ST segment, The difference between the two is that a STEMI is going to be one of those things that is like a primary problem. If you have an NSTEMI versus a STEMI come in, like if they both came in at the same time, STEMI is going to go first to the cath lab because they're at highest risk for full-blown myocardial um t like cell death in that area. Versus an NSTEMI, if you think of like a straw, a STEMI would be something is stuck in the straw and you can't get anything like through, either going through it, like blowing through it, or sucking in through it. So everything around that area, since there's a full blockage, is going to die out because of the lack of blood flow. And a NSTEMI, still the same straw, but instead of it being like a full blockage, it's only like half of the diameter of the straw. So anything that's still open is going to be okay. Fluid can go through it, or you can suck fluid or push fluid out through it. But anything that's on that opposite half where that blockage is, that's the area where it's not getting any oxygen, and that's where you'll get cell death. So there is a treatment that we give when they first come in. Morphine, oxygen, nitroglycerin, pain. Beta blockers is something else that you'll see. These are the different reasons why. Morphine can also be given for their anxiety because they'll have like a overwhelmingly crushing chest pain / they'll state that they feel like they're dying. And then the other thing to make sure that you keep in mind is that they can go into shock because of their MI. So the reason why they go into shock is because that area where there's reduced blood flow can obviously decrease the tissue perfusion, and leads to that cellular damage. So we have to make sure that we're going to cath lab within 90 minutes for a STEMI to make sure we open that artery back up and increase perfusion. For the NSTEMI, sometimes if you give a thrombolytic, it kind of prevents it. They may not have to get a PCI, but we're still trying to restore perfusion to that area. If they go into shock and they start crashing, we'll give them vasopressors like Levophed or Norepi, which are basically the same thing, to bring up their pressures. You may also see atropine, it just depends. And we need to make sure we treat the underlying cause. In this case, for an myocardial infarction, they're having a pump failure. Infection is more going to be sepsis, and a hemorrhage is going to be hypovolemic shock. For a myocardial infarction, they're having a pump failure. Okay. So, AFib. Remember that this is an irregular rhythm. If you see that as a choice, it's irregularly irregular because there's going to be an absence of the P waves at the very beginning of the EKG, which tells you that the atria are not doing what they're supposed to be doing. And what we're really trying to do is control the rate and the rhythm. And because our atria are kind of flopping around is a bad word, but that's kind of how I remember it. Because they're kind of flopping around, they need anticoagulants, and the anticoagulants are just going to help them be like prevent clots and stuff like that and be a little bit more stable. And then hypertension. So hypertension is going to be, obviously we all know hypertension is an elevated blood pressure. And a lot of times it's symptomatic, but we have to make sure that we're telling them to regularly take their medications and to modify their lifestyle. And that's going to help hopefully prevent another MI in the future. And if it's their first getting diagnosed with it, we're trying to prevent an MI just in general, if that makes sense. All right. I am going to just give you guys a little bit to look at this case study. So right now would be a good time to pause, and then I want you guys in the comments to comment kind of what you think is going on, and I'll answer your comments. So pause here. All right. And then these are just ways that we can help our patients reduce their risk for heart failure, MI, all of that sort of thing. A lot of it is going to be making sure that they're going to screenings, getting their yearly physical, making sure that they're eating healthy, they're doing exercise, and um, reducing their alcohol intake as well as smoking cessation are going to be very, very important for reducing cardiovascular events. And then here's just some things that I want you guys to remember that are going to be very important for your exam. Please don't forget to make sure that with everything when we're talking about pathophys, health assessment, make sure you understand the why behind the what. And also, if you do know your physiology of a patient, your exams, even when you go into nursing and you're actually doing a physical exam, don't become memorization. You're not remembering each piece and what to do what and that sort of thing. You're starting to piece together little points that tell a story. Every patient's background has a story, and you, as the nurse, are telling that story. And your charting should explain how all of those pieces fit together and brought your patient to be where they are at this point. Okay, well, that's all I have for you guys today. Look for that other video, and I will see you guys soon. Have a great day. Happy studying. Bye.